Welcome to Motivational Interviewing, the steps. In this session, we're going to identify the basic steps in motivational interviewing, or MI, as well as the core skills involved. The 4 steps of the motivational interviewing process are engage, focus, evoke, and plan. Let's take a brief look at each one now, and then come back and think about what is involved in each one. All quality interactions start with an initial conversation to break the ice and build rapport. As the earlier program emphasized, compassion and empathy are the foundation of MI. So we start by asking permission to discuss the behavioral health topic with the person. Engage the person using open-ended questions, empathic reflections, autonomy supportive affirmations, and rolling with resistance if needed. Focus on understanding what your patient is saying and how he or she feels. Empathize with the person's perspective. Focus by reflecting, summarizing, and developing discrepancies. The next step is to respectfully evoke your patient's thoughts, feelings, motivation, and concerns. That is, get the discussion going and directed at underlying concerns that might increase or decrease motivation to change. Given the person's responses and readiness to change, the next step is to talk about a plan for change. In some cases, the plan may just be to talk about it again later if the person isn't ready. Now let's explore the MI core skills that support using the 4 steps. Open-ended questions, affirmations, reflective listening, and summaries are the primary skills necessary to practice and provide the foundation of motivational interviewing. Change occurs when people give voice to their own reasons for change. These skills encourage the patient to explore problems and to talk. The skills are summarized by the acronym OARS. OARS are derived largely from patient-centered counseling, but in MI they are used for the particular purpose of helping people explore their ambivalence and clarify reasons to change. By asking open-ended questions, the stage is set to use aspects of reflective listening, affirmations, and summarizing. Open-ended questions encourage the patient to do most of the talking, help us avoid premature judgments, and keep communication moving forward. Open-ended questions provide a way to gain broad descriptive information. Open-ended questions usually start with words such as how, what, tell me about, and describe to help the patient open up and talk about concerns and perspectives. In most cases, we start with general questions and then get more specific to clarify and focus on key issues. An example of an open-ended question is, tell me about your reasons for wanting to lose weight. What are your primary concerns? Using open-ended questions avoids the question-answer trap, a pattern where the clinician asks questions and the patient gives short responses, often yes or no. This pattern teaches the patient to give short answers and subtly implies the clinician is the active expert and the patient is passive. In other words, the clinician, not the person, has the solutions to problems. This is not motivational interviewing. In MI, the patient does half or more of the talking. Open-ended questions afford the person the opportunity to explore ambivalence and offer change talk. Asking a series of closed-ended questions, or even a series of open-ended questions, is not as effective as using a mix of open-ended questions and, most importantly, reflective listening. As a general guideline, the clinician should avoid asking 3 questions in a row. Closed-ended questions gather very narrow, specific information and tend to solicit yes or no answers, or 1 or 2 word answers. They convey that the agenda is about something other than the patient, like the clinician's need to gather information or complete a form. Examples include questions like, "Are you having any pain today? Is there anything that is worrying you right now? Are you short of breath? Have you tried this exercise?" Think about how you would turn this closed-ended question into an open one. Do you feel depressed or anxious? A few possible options are listed here. The point is that the open-ended approach will get more description about the person's experience than the yes or no response to feeling depressed or anxious. As the slide suggests, affirmations are used to complement the person's view or efforts and express appreciation and understanding of both difficulties and strengths in coping with problems. Affirmations promote self-confidence and efficacy, which are necessary ingredients for change. Affirmations can also help us acknowledge the difficulties the patient has experienced. We can emphasize past experiences that demonstrate strength and success to prevent discouragement. We validate the patient's experience and feelings and reinforce open exploration of a patient's problem. When sincere, affirmations build rapport and facilitate change. As illustrated on the slide, affirmations may be a positive comment on an attribute, a statement of appreciation, or a compliment. Remember, appreciation may recognize and validate the physical or emotional distress associated with behavioral health challenges. Reflective listening is another foundational skill in MI. It can be a challenging skill to learn, but is well worth the time and practice since it's essential to expressing empathy. We reflect back what was said to make sure we have accurately heard and understood the person's meaning. Reflective listening is the key. That means listening with the intention of understanding the person's viewpoint, and then reflecting ideas or issues back to the person in a non-judgmental way. Reflecting what the person said can be just a simple restatement, but in slightly different words. The goal is to stay close to the message and not go further. Another way of reflecting is to make a guess about what the person has said. More complex reflections can also guess about the underlying feelings the person has. In the example on the slide, the person didn't say he was disappointed, but that might be an important part of their discussion. How disappointed he is with not having support and help to make changes. Finally, the double-sided approach reflects back on both sides of the issue. This gets at the ambivalence the person has, which is important in helping them tip the balance to try something different. Communication roadblocks occur when responses do not show reflective listening. Advising, warning, judging, and trying to persuade routinely close down communication. The patient concludes we just don't get it and there is no point in talking. Finally, discussions are often helped by occasional short summaries. Summaries reinforce what has been said, show you have been listening carefully, and prepare the patient to move on. Summaries can be used to begin and end sessions and provide transitions from one topic to another. Summaries don't have to be comprehensive. You can select what information to include, minimize, or leave out to best reinforce talk about change. You can also add information to help amplify the patient's feelings of ambivalence. Double-sided reflections, statements that look at both sides of an issue, can also be effective as summaries about the person's ambivalence. In the next part of the program, we will look at additional tools used in motivational interviewing and introduce the brief intervention, which is based on MI. We will also take a close look at the change process. Thanks to our funding agency for supporting this program.